consultant in acute medicine at the Hampshire Hospital, National Clinical Director for Infectious and Management of Deterioration. He also is the chairman of COVID pathway groups at the NHSC, England. In COVID-19, Dr. Matt did a lot of work, especially in handling cases in hospital-based, also home-based. And as you know, most of us, we know that UK is one of the countries which is very successful in home-based care of COVID-19 patients compared to other countries. So we are lucky this evening that we have Kim with us. So I think we're going to learn a lot of things, especially in this situation where there is a threat of third wave. I think we need home-based care to be, for health professionals in Tanzania to be very competent in handling home-based care of COVID-19 patients. So Dr. Kim is much interested in developing standardized language in sickness. He succeeded to develop standardized language of sickness and communication between healthcare professionals across the whole patient pathway of COVID patient. So this is the good thing Matt did in COVID-19. So also we are lucky to have Matt this evening, and thank you, God, that we're going to be, this discussion is going to be fruitful through these two guest speakers. And the last speaker is the host speaker. This is Dr. Elisha Osat. This is the immediate past president of MAT, of Medical Association of Tanzania, and she's a specialist at Muhimbili National Hospital. This is the biggest hospital in the country. We call it a center of excellence. And she's specialized, he's specialized in cardiopulmonary diseases. Also is going to be with us, and I think he's going to be the first speaker. But in conjunction to this, it is very important for me to rain special thanks or gratitude to Dr. Mwidimi Ndosi, all the way in the United States of America. He did a very good work in organizing this meeting. Thank you so much, brother. Thank you for your generosity in organizing this meeting for the benefit of your country. The second one, I would like to thank you, Dr. Buguzi. Currently is studying at the Sheffield University, UK. He did a very good work in coverage, in social media coverage. Thank you so much, brother, Dr. Buguzi. And the third one, I would like to thank you, Donatus Mtasigwa, and his contribution on how to put this or installation of the topic is a very important thing. So thank you so much, Dr. Donatus. Yeah, after saying this, I would like to turn this to the host speaker to continue with the timetable. I think everyone will be ready to listen from our speaker. Thank you so much.
Welcome, Trishna.
It's me next.
Yes,
okay.
Absolutely.
Sorry, I will share my screen. Okay, well, thank you very much indeed for inviting me to speak. It's really a privilege to join you in your country by Zoom and talk about prevention of COVID-19 in Tanzania. I've never been to Tanzania, but my son has spent some time. He's a young doctor. He spent some time in Tanzania. So everything I have got wrong about Tanzania here is, you can blame my son. I just also want to thank Rebecca Inglis, who's made some of the slides for me. So let's get on. Can I just ask, you can now see my second slide? Is that right?
Yes.
Yeah, great. Now, I'm not going to spend a lot of time trying to persuade you that the SARS-CoV-2 virus is airborne. We've already written a paper for The Lancet called 10 Reasons in Support of Airborne Transmission. And since that paper was published about a month ago, people have come up with more reasons, 11, 12, 13 reasons. There's many, many streams of evidence which show quite definitively that this virus spreads through the air, and almost certainly airborne spread is the predominant route of transmission. Now, I know that not everyone believes that, but there is a lot of scientific evidence for it. And everything I go on to say is going to be about preventing airborne transmission. It is important also to note that tuberculosis is also an airborne disease. So all the measures that we're going to talk about are also going to be effective in the prevention of the spread of tuberculosis. I think I'm right in saying that more people are dying of TB in Africa at the moment than are dying of COVID. So let's not forget other infectious diseases. Now, probably many of you know the basics of prevention already, and I don't want to patronize you. You know the message probably: hands, face, space, ventilate. What they were used to say, the WHO were very keen on hand washing initially because they assumed that the virus was spread by droplets. And yes, it is true, we should be washing our hands. Hand washing prevents diarrheal disease. It may help prevent the spread of COVID, but actually the hand washing needs to be put in perspective, because masking, in other words, covering the face, physical distancing, sometimes called social distancing of 2 meters, that's really important, both to prevent droplet spread, but also because aerosol transmission occurs mainly within 2 meters. It also occurs beyond 2 meters, but if we can keep physically distant from people, that is a really good way of preventing spread. But most importantly, ventilate. And this is the new one. This has only been added to the WHO recommendations in the last maybe 2 or 3 months. The Japanese, in fact, began very, very early in February 2020 with this 3 C's slogan: avoid the 3 C's, avoid crowds, avoid closed spaces, and close contact. And that was because Japanese researchers believed from the outset that COVID-19, the virus causing COVID-19, was airborne. So we're moving from a prevention strategy that focused predominantly on hand washing to one that embraces ventilation and space as really key measures. And as I put on the top of the slide, the prevention measures need to be very simple. They need to be culturally congruent and available in all the languages spoken locally. Very, very important. So here's another poster. These posters you can download from the CDC website in Atlanta in America. Many of you be familiar with them already, but if you simply put CDC into Google and then put in the word Swahili, you get lots of interesting posters which you can download and use. Now, because COVID spreads in the air, because the virus spreads in the air, indoors is much more dangerous than outdoors, and closed spaces are very, very dangerous for the transmission of this disease, especially if you are spending a long time in those closed spaces. So 2 particular things are really, really risky. One is travel in buses or trains or taxis that have the windows closed and have a roof on, and also the working environment. You can see here, people are at work, but there's a lot of people in that room. And yeah, maybe there's a window open, but it's not a very big window compared to the size of the room. So these are highly risky situations. Very sadly, communal worship is also high risk. There are many super spreader events that have happened in church. This virus is not a respecter of the sacred space. Singing and chanting, anything that involves vocalization, is a big problem because it produces aerosols. It doesn't produce many droplets, but it produces aerosolized virus. And so in my country, in a church now, you don't sing anymore, and it's really sad. My mother died of COVID, and we had a funeral with no singing because singing is a really dangerous thing to do. And yes, that's sad, but it's not as sad as the deaths that would be caused if people did sing. Now, here's some measures for people who are already sick. If you have a temperature, a cough, perhaps gastrointestinal symptoms, you know, the varied presentation of acute COVID. If somebody is sick, they should wear a mask in the home. They should stay home except to get medical care. They should isolate from other family members. In other words, they have to spend time in their bedroom rather than in the living room, especially if that person has an elderly relative or a vulnerable relative who would perhaps do badly if they developed COVID themselves. They should tell their close contacts, get tested. I've tested positive, or I think I might have COVID, go and get a test. Do not share household items, that's pretty obvious. Monitor symptoms, because of course it's in the second week of COVID, as Matt Inada Kim is going to go on to tell you, that people might deteriorate. So monitor symptoms is important. And the last thing, sneeze into a tissue. So those are the kind of measures that we need to get across to people if they are sick. And remember, many people with COVID are not very sick. They may only have minor symptoms, but they can be highly contagious. And so it's really important to get across the message that you must quarantine at home if you're exposed, but particularly if you've got any level of symptoms. Now, there's a lot of new research about what kind of mask is effective. Now, a year ago, I was telling people any mask is okay because it stops the droplets coming out of your mouth. And that's true, it does stop droplets. But what we're now realizing is that in order to stop aerosols, we have to really make sure that any air that comes out of the mouth and the nose is blocked by the mask. It can't go around the sides. So the fit of the mask is very, very important. And there's been some interesting tests, experiments particularly in America, on the escape of air around the sides of a mask. And you can see on the left-hand side, these two pictures, that one really effective way of masking is to put on a medical mask and then a cloth mask over the top of it. So it's called double masking, because the medical mask is a good filter, but it often has gaps around the sides. But the cloth mask can go over that and make it fit more closely. Another way of doing that is, instead of putting a cloth mask over the top, to tie a knot in the side. And I'm going to show you another slide with a better view of that in the next slide. You can buy what's called a mask fitter, which is basically a kind of three-dimensional rubber band to go over it. And the other thing you can do is put some nylon over the mask. In other words, a pair of ladies, what we in the UK call tights and the Americans call pantyhose. I have no idea what you call them in Tanzania, but you cut up an old pair of women's tights and put those over the mask, and that will keep it snug over the face. So lots of different ways there. Here's a picture of how to fit the mask closely. You can see the side gap there on the left. You can see the cloth mask over the top of the medical mask, and then on the right-hand side, the way of knotting the medical mask right close to the side of the mask and then hooking the ear loops over. Now, I want to talk you through the COVID risk chart. This is a chart that I made for a paper that we published in the British Medical Journal more than a year ago now, of the risk of SARS-CoV-2 transmission in different settings. And it's a little bit schematic. We have now quantified the colors. The colors are really just an estimate of the risk. So green is low risk, yellow is medium risk, and red is high risk. But we've now produced quantified estimates of those. And we're about to publish a new paper, but this is good enough. It's a pretty good estimate. We didn't get it badly wrong. So the top row is people who are wearing masks or face coverings, and they're only in contact for a very short time. And on the left is low occupancy, where there's not many people in the room, and on the right is high occupancy. And you can see that with low occupancy, if people are wearing face coverings, not there for a long time, you're okay, really. The only risk is really when they're vocalizing quite loudly, shouting or singing, and they're crowded and in a poorly ventilated indoor space. But otherwise, if you're wearing a mask and you're not in there for very long, say you're popping into the shop, if your mask is fitting you, that's pretty good. You can see the next row is the same pattern, but the contact is more prolonged. And you can see that particularly poorly ventilated spaces are much higher risk simply because you're there for longer. And then the next row is where people are not wearing masks, and the risk increases quite substantially, even when there is low occupancy, even when it's not so crowded. And finally, at the bottom, the last row is no face coverings and contact for a prolonged time. And really, if you're doing that, if you're going into a room for a long time and it's crowded and someone is in there who is contagious for COVID, you may very well catch it. So that's a rough risk chart, which we've found very useful. It's been translated into more than 50 languages. If you put the hashtag COVID risk chart into Google, you'll be able to download these. And the British Medical Journal is very happy for people to print them off and put them up if they're helpful. If you'd like to translate it into a new language, get in touch with me. As you can see, we've got Swahili already, but I know there's lots of local languages, so I can give you the Word document of that. Now, I want to talk a little bit about improving ventilation in buildings, because ventilation is absolutely key. And interestingly, when I was looking for posters and videos and things in Swahili, when I just thought, what's already available in one of the main languages of Tanzania? Actually, there's very little about ventilation. There's a lot about hand washing. There's a lot about masks and physical distancing, but I couldn't find much about ventilation. And yet ventilation is crucial. So there's a job for someone to make some posters about ventilation. So I'm going to just I'm going to show you now Rebecca Inglis's pictures, which she made for Laos, actually, a different country, but I think similar kind of income levels, similar climate, I think. So I don't think the pictures are going to be very inappropriate. For example, here, the safest way to minimize the transmission is by being outside. You can see here the top of a tent, but the sides of the tent don't exist. You know, it's just a roof. So that is a great setting, much better than being indoors, because if you're indoors, the levels of the virus build up. If you are indoors, monitor the carbon dioxide levels. You can get a machine relatively cheaply, and you don't need one for every room. They're very small, they're very portable, and you can carry them from room to room. So you only really need one per business or one per hospital or something like that. Now, the outdoor level of carbon dioxide is about 400 parts per million. Inside, ideally, 400 to 600. It's okay if it's 600 to 800, but once you get above 800, what that indicates is there's a lot of exhaled air in that room. People are breathing out, and it's not dissipating into the air. It's unsafe to go above 1300. And if you look on Twitter, don't know whether you're Twitter followers, people will sometimes show pictures of CO2 monitor levels in stuffy rooms with the windows closed, and it'll be going up over 2000. And that is very, very problematic. Okay, so open the windows, keep the windows open. And where possible, and this is beautifully illustrated in this room, open windows on two sides of a room so that you get a through draft, because it's the air passing through that's important. We've all seen hospital waiting rooms like this. The more people that are in the room, the higher the risk, especially sometimes people sit for hours waiting to see the doctor or the nurse. Get them to wait outside if possible. And I had to do this myself the other day. I went to the dentist and I stood outside for 20 minutes. And I wasn't the only one. People were very annoyed. Why can't we go indoors and sit down? The answer is because they're controlling the risk. Set your extractor fans to blow outwards. That is what they were designed to do, but many of them have been fitted incorrectly. So make sure they haven't been. Check the direction by holding a piece of tissue up to the blower. Unblock the air vents. I mean, people talk about these fancy filters and things that you can buy, very expensive filters, but perhaps the first thing you can do is go and check the air vents and take off the sticky tape that someone put on there to stop the draft. We need drafts. Use your fans carefully. It's no good really if the windows are not open. You need to open the windows because otherwise the fan is just blowing contaminated air around. Make sure the fan is blowing from a clean area to a less clean area. So in this, the nurse's station blowing towards the patient area rather than the other way round, on the assumption that the patients are more likely to have COVID than the nurses. Let's hope that's the case. Also important to make sure the fans are positioned so they don't blow the infected air from one person to another. There's been a number of studies in restaurants where the air conditioning or the fans have blown the infected air from one person across to others. So use your imagination with these fans. Be careful with air conditioning. It feels lovely, doesn't it? It feels really clean because it's cool. But if they are simply recycling air, then it's an illusion that this air is clean. It's not clean. Now, what they say here is that if you've got a single room with a patient in, the patient is sick, they've got a fever, it's humane, it's kind to cool that room, make the patient comfortable. But then what you need to do is when the staff go in, you've got to open the window and let that air out and get some fresh air in rather than build up, because otherwise that patient's going to infect other patients and staff. Here's a nice kind of vehicle for transporting patients. I don't know if you have these in Tanzania, but it hasn't got any windows or doors. That's much better than one of those modern looking ones with the closed sides. Now, staff rooms are really dangerous for doctors, nurses catching COVID from each other. You health professionals are at high risk of developing COVID and passing it on to one another. And the place where you're most likely to share it is in those lovely rooms where you go for your rest and your food and talking to each other. So you need to avoid overcrowding. Preferably grab your lunch, put it on a plate and take it outside to eat it rather than stay indoors in the staff room. Optimize your mechanical ventilation. I've no idea what things are like in your hospital buildings, but some hospitals have these inbuilt mechanical ventilation systems because they're pumping fresh air into the building. So that's a good thing. But make sure they're properly serviced and that they've been set up appropriately. Finally, I've learned a new term in my new expertise on airborne infection, which is HEPA. It stands for high efficiency particulate air, and it can filter up to 99% of this virus from room air. So these are much more efficient than the standard, what they call MERV filters. But these filters, again, have got to be put in properly. They've got to be sealed in place. They've got to be replaced frequently because otherwise they don't work. And so you assume it's filtering the air, but it's not really. So that's all I've got to say for now. I will be available both live and also on Twitter for a while afterwards to answer your questions. I'm sure I've forgotten all sorts of things, but you'll tell me what those are and I'll try and answer them. So thank you again, and I will hand back to the chair and stop sharing my screen.
Fantastic. Fantastic, Trish. That's really informative. Thank you very much for that. It's just while we're thinking about that and people are putting questions there, shall we invite Matt to go on? If you, please. Thank you.
Yeah, of course. Thank you. And thank you, Trish. Fantastic talk as always. Just going to try on my screen and slides. So it's very nice to meet you all, and thank you very much for your kind introduction. I guess I'm the bit after Trish. So if we don't manage to successfully prevent infection, particularly in community settings, how can we best manage COVID in, I guess, the ultimate healthcare environment, which is people's own homes? What we found in England is not dissimilar to what was seen all around the world in patients presenting quite late sometimes with quite severe COVID, because it doesn't present with classical symptoms of breathlessness as many respiratory illnesses do, for instance. And it woke us up to thinking about rewriting our textbooks to look at more general symptoms and signs that a patient might not be well, but not purely focused around this concept of breathlessness. So whilst breathlessness is predictive, it's not always present. And as this horrendous case demonstrates, and this was replicated all around England and indeed around the world, we needed to be vigilant with other signs. So the concept of silent hypoxia, of presenting with very low oxygen levels with an absence of breathlessness, was coined quite early on in the pandemic. And it made us realize that this battle was not going to be won by ventilators and hospitals and by all the technology that we could throw at this illness, but was going to be managed through best case management at home, educating the general public and ensuring that they were escalated and they had the ability to monitor themselves where appropriate, to seek help at the earliest opportunity should they start to deteriorate. So all this was around how we protect patients in the course of their illness, but also how we protect the healthcare system. Because the healthcare system has got to be there for people that significantly deteriorate. And unfortunately, we lack the resources to have a healthcare system that deals with milder illness sometimes, particularly in the course of a pandemic. So we began last year, and Trish and colleagues wrote this really good article on very sensible advice on how best we should do remote assessments with COVID. And it was really important work for us because we quickly realized that we would not be able to see patients with early symptoms of COVID, both because of scale, but also for the practicalities of an infectious disease process. So this very common sense guidance, which I urge you to read, really looked at how you could best do take histories, what significant symptoms might be, and how you might begin to do examination over the phone, or if you're lucky enough to have an internet connection, over telemedicine and FaceTime. And then a decision and action tool thereafter. And it really rose the question of, well, oxygen saturations, we agree, is a really important element of assessment. What if we could do this everywhere? And if we did this everywhere, could we start to prevent some of the avoidable deaths we potentially saw during first peak? And it really rose the question about what we needed, which was hopefully to come in the next few weeks, a validated scoring system for assessing patients in the community and at the interfaces of care to determine who is at highest risk and might need urgent hospital attention. And really early on in the pandemic, certainly in this country, we began pulling together the arrangements to track patients and their processes all the way from home to the ambulance service and to the hospital, and then all the departments in the hospital, to figure out what the early signs of deterioration were in the community at patients' own homes. And what we found after quite in-depth study was that oxygen saturations are probably the best predictor of whether a patient is likely to die end up requiring ventilation or end up requiring an admission. And what we found was that 92% or below appeared to be the magic number in terms of prediction of 5-day mortality, 30-day mortality, and indeed intensive care mortality and admission as well. So that cutoff of 92% or below appeared significantly different from 93% or above. And it felt like a good line in the sand as a result. And that's why we based our national guidance around those very simple, clear metrics. 92% or below, go and seek help. 93 to 94 being an amber type group where you need to watch carefully. 95 to 100, generally in the absence of severe symptoms, is a patient who is at that present time okay. And the other important thing from that research was demonstrating that actually a lot of the admissions and people attending hospital had normal oxygen levels in the 95 to 100% range and were therefore milder risk. And this was really important. Rather than admitting everyone, but turning off the tap of admissions to ensure we had flow through the emergency care sector. And this is a graph demonstrating that composite outcome of mortality and intensive care admission and showing that steep climb at 92% or below. What this led to was the purchase of large numbers of oximeters, around 700,000 oximeters across the country, and then eventually a national mandate to get home oxygen monitoring done across the country. There has been chatter about whether there is inaccuracies with pulse oximetry in darker skin. And the overall take-home message is the benefits significantly outweigh the risks by some margin. And although we need to do further research into this, because at the moment the research is not of high quality, in England, certainly, we have not seen any incidents where there have been inaccuracies in the course of clinical care. And that's after distributing 500,000 oximeters. And the advice really is record that baseline oxygen saturation where possible, compare subsequent readings against that baseline, and never forget clinical judgment and the trends of both symptoms and saturation readings for patients over time. So the overview for this strategy is around how we protect patients and how do we protect healthcare systems, because there's limited capacity for both. From a patient perspective, it's cluing them up into what the bad signs are, what the good signs are, and when and how they should conduct themselves in the home environment to prevent spread to others and their nearly or loved ones. And then from protecting the healthcare system, it's really important we get the flow right to ensure that admissions come in appropriately, discharges go early and in a period of stability, and that we don't overcrowd or overwhelm the healthcare system. And the model itself of remote home monitoring is based around a very flexible model based on the resources available, be it in a village or an urban center, a very poor area or a very rich area. And this is the spread in every single country around the world. There are places in every part of the world where we don't have oximeters, where we don't have teleconsultations or video chats, where actually good advice about what symptoms to look out for are really important, and safety netting advice for when people should seek help and what they should be worried about. And that should be a pattern in everywhere. And as we get more tech savvy and as we get more income and resource, we spread towards oximetry monitoring, potentially with diaries and instructions to patients, videos and YouTubes on how to spot the bad signs within COVID and how to monitor yourself and track yourself. And then in the ultra high resourced areas, the use of apps or dashboards together with teleconsultations. But it's not a one size fits all. There is a variable model based on the resource that's available. And that's really important going forward. And it was across the world. Not everyone has access to a smartphone that is linked to telemedicine or consultation. We need the basics as well. And actually, the basics are probably the most important elements. There has been a lot of talk about what treatments help with COVID, and we did quite a lot of study into the use of budesonide inhalers. And unfortunately, at the moment, the readout does not suggest it improves hospitalization or deaths. Further studies are obviously underway, and we hope it will, some will prove some favorable evidence, but the current statement is that it's not for wide-scale prescriptions because it hasn't demonstrated improvement, at least in England. It did purport to a slightly improved recovery time, but it was difficult to separate that from a potential placebo effect. So this is important. An important part of, I guess, pandemic preparation is also using resources appropriately and not going down rabbit holes. And you need to be very careful with the finances and resources we have to invest in the things that actually have evidence behind them and that work. So back to the concept of virtual care or care for patients with COVID at home. Now, this green group is 90% of patients with COVID in a really important area. Instruction, information, and trust between clinician and healthcare system and the patient is really important. We need to inform people what normal looks like. You know, when should you get worried, but also when you should not get worried, when not to contact the healthcare system, because you realize this is the normal course of illness. We have to realize early on who the high risk categories of patients are and who are the much lower risks, and to reassure patients that normal recovery takes 2 to 4 weeks. You're not going to feel amazing until you get through that period, and maybe don't contact your healthcare provider unless you trigger atypical symptoms beyond these. We know what the more benign symptoms are with COVID. We know that having a cough or expectorating sputum or having a loss of sense of smell or taste, whilst potentially being predictive of having COVID, does not predict that you are going to die or that you're going to require a hospital admission. And again, this is really important to reinforce to patients. Look out for these symptoms, they're usual symptoms, but don't worry about them unless you develop more severe signs. And this is the other arm of this information to patients, this partnership. What are the severe signs? When should I worry? What are the symptoms that are most dangerous? And when should I be feeling better or worse? And what's really important in line with those green kind of milder symptoms is also thinking about what the severe symptoms are. And although we know breathlessness, severe myalgia, severe fatigue, chills, rigors are quite significant predictors of those with COVID who end up either dead or in intensive care or needing an admission, it is important the general public are also aware of those symptoms as being the kind of red flag symptoms. And also that the onset of silent hypoxia is usually at days 5 to 7. And if you're going to develop significant breathlessness, 95% of the time it's between days 7 and 11. And again, that's really important in heightening the public's awareness of when the danger zones are, both in terms of symptoms and also the timing. And if they're lucky enough to have an oximeter, what those significant oxygen levels are. And also the warning that if you do note an incredible rapid onset of breathlessness, that's a time to get worried. If you can't speak in short sentences without getting breathless, and if you describe breathlessness at rest, that's a really important constellation of symptoms. So safety netting guidance is really important. And we produce this in England, but you're very welcome to have it and translate it if it's of use. And we can share all the links afterwards in terms of what we've done. So across England, this was a project that was really born from clinical care. Patients and clinicians saw the value of educating the public and empowering them with pulse oximeters right from the start. And it was an easy sell to the medical profession and the nursing profession in England as a result. It was a harder sell actually to get government to back it initially, because the evidence was slow to come, and it's still slow to come, as you can imagine. It makes common sense from a clinical perspective, because why should you not monitor patients? And it makes common sense from a patient perspective, because they want to know what the bad signs are to look out for. And what we found was that key elements in terms of that national distribution were around the engagement, not just socially and politically, but also religious groups, as well as medical leadership. And then to develop a strategy of how we would fund and support regions attempting to implement this strategy with regional webinars, learning events, e-forums and discussion forums, and resources that contain guidance, pathways, training materials that were shared widely and free of charge to ensure that everyone had access to a common vision and all of the materials required to implement it, with the ask in the future that we would collect the data and prove that this made a difference, and more of that later. So these learning resources are on websites, and again, all these links are available that teach healthcare professionals how to monitor patients with COVID at home, and indeed the guidelines and pathways that we utilised, that we got to through errors in the beginning. To be honest, we made errors and we learned from our mistakes. to get to the point where things are improving in terms of how we monitor and measure and manage patients with COVID in the home environment. And then toolkits for how do you step up and start a service from scratch within an hour? And how can you do this really quickly where the need arises? And an ongoing learning network that still meets today and has hundreds of members up and down the country. And that's a really powerful element in terms of that collaboration and the family that is healthcare, trying to provide its very best for patients everywhere. And this implementation across the small country of England occurred in quite rapid progression. So it was built around the early identification and protecting patients and protecting the healthcare system. And we started off at about a third of the country in December last year, moving quickly to 60%. And then by February, 100% of the whole country doing it. We divided the country up into populations of around 10 million in each sort of cell for improvement as a region to try and base a unified strategy around. And that seemed to work for us. It's difficult to do an entire national strategy immediately just from your capital. It is more sensible to think about regions. What I guess the key element from a simple perspective for the general public and also for religious leaders or cultural or social leaders in parts of rural parts of the country and spread all over was around those tenets of look out for symptoms, how variable this model could be based on your resource. But at the end of the day, it was about spotting that early deterioration. And if a patient came into hospital, ensuring that once stability was reached and recovery was reached, discharge was expedited in order to clear the healthcare system as soon as possible and get ready for the next patient, essentially. And, the model was warmly liked from a hospital perspective. Again, we tried to simplify things as much as possible down to those 92% or less oxygen saturations, and then thinking about discharge upon recovery, really. And it resonated with clinicians because it was simple. We also used walking tests of actually getting people to exert themselves over a 40-step walk distance or getting them to sit up and stand up repeatedly over a minute to actually examine for evidence of desaturation on exertion. So much like pneumocystis carinii pneumonia from all those years ago with HIV, COVID is a condition that causes this desaturation. And again, it was something that we had to rewrite the textbooks around and make clinicians aware of this, again, in terms of looking out for severe signs. The discharge arm was also really important. So improving clinical trajectory was a gear to getting people out of hospitals early, even without supernormal oxygen saturation levels. Because actually, once patients are on a recovery phase, they're generally going to do all right. And it's important to obviously clear the beds when we are overwhelmed with numbers of patients. So we put in protocols in large parts of the country to think about early highlighting of potential discharges, early medical review to get patients out, and then with a view to getting people out under virtual care, or what we called a virtual ward, where we were able to still intervene with hospital type treatments, including drugs like dexamethasone, without necessarily occupying a hospital bed. And this is an important strategy going forward. And early studies from around the world demonstrate that actually even treatment with oxygen at home via oxygen concentrators appears to be a safe thing to do in patients that you rapidly discharge with low oxygen levels who are on a recovery phase. So there is evidence growing in this area about the benefits, as well as steroids, both at home and in the hospital. The overall impact from a national perspective was a dramatic reduction in length of stay, which has been a really pivotal element in keeping our hospitals going and allowing us to restore function for things like elective surgery or other healthcare requirements in a hospital. And this reduction in length of stay and improved flow was accompanied by a reduction in mortality rates, about a third reduction. It wasn't just this virtual remote monitoring approach, but remote monitoring was a key element that led to this. It was a safe model of care with an overall mortality rate for patients monitored in this non-hospital environment of less than 1%, which is actually far better than we did with admitted hospital COVID patients during first peak. And the impact from a hospital perspective was that the green line here in the bottom right relates to COVID virtual care patients. The red line is hospital admissions. And what we found is we were able to rapidly reduce the numbers of admitted patients to beds and increase that virtual activity to keep our hospitals running, essentially. And that pattern has continued all around the country. Early evidence is also suggesting that by putting people on a home monitoring program such as this with oximetry or with symptom advice, you get a reduction in future hospital attendance from a COVID patient and hospital admission, with quite a dramatic 30 to 38% reduction in the relative risk of a hospital admission. Again, this is really important, thinking about how we are going to keep our hospitals from being overwhelmed should another pandemic occur. And this concept of maintaining capacity is really important, and the concept of whether lower acuity admission areas would be necessary in the event of complete health system overall overwhelmingness, and whether there was collapse, and learning lessons from China and the Fangdang hospitals that were 13,000 bedded size, and what we might need to do should we become overwhelmed. So we had this in our back pocket in my region, because at the end of the day, we didn't know whether we were going to be able to cope with the vast numbers we saw during second peak, and indeed what we may soon see within third peak. So it was a question of keeping a really careful eye on whether non-hospital utilization to admit those patients who are lower acuity earlier on for oxygen concentrators where necessary, potentially drugs like dexamethasone, but keep them out of your intensive care hospitals and save those intensive care hospitals for those that were really sick. And it's another strategy, I guess, if we get to a point where we become completely overwhelmed with another pandemic. So in summary, this has now been recommended as a strategy by the WHO as a conditional recommendation. And the principles are really simple. It's about flow through the emergency care system. It's about trust with patients in their own home environments, simplicity of advice for patients about what they should and shouldn't look out for and when they should or shouldn't seek help, protecting patients and protecting the healthcare system to ensure that it can still function in the face of a pandemic. And there are amazing examples around the world. And one is Step 1 in India, which currently looks after 400,000 COVID patients at home remotely, and is a great example, and I'm very happy to, I'm sure, to have a conversation with you. They have 85,000 new COVID cases a day and have done remarkably in the face of an incredible COVID pandemic, as I'm sure you're aware. So thank you so much for inviting us to talk today, and we'd be very happy to answer any questions.
Fantastic. Oh. It's fantastic. Thank you very much, Matt, for that. It's really fantastic talk here, and there's quite a lot of questions will be coming, I'm sure. And I will let Dr. Elisha Osati come now. I think there was a problem somewhere. Please, Dr. Elisha.
Yes, Mudimi, I'm around. And I really would like to thank everybody for Prof. Trish and Matthew for a very nice presentation, and Dr. Shadrach, President, for the introduction. Mine is very minor, just an update of the COVID situation in Tanzania, on what is currently going on in Tanzania, and how we have been since the first case of COVID has been announced in the country. So if you can allow me to share my screen a bit. Okay. All right. So I'm just going to give, as I said, a very brief updates on the COVID in Tanzania. So as I've been introduced, I'm Dr. Elisha Osati. I'm an internal medicine physician at Muhimbili National Hospital. I'm working in the pulmonology and cardiology unit. But also I've been the president of the 19th president of Medical Association of Tanzania and immediate past president. So I think we can remember, I saw the picture there of our former Minister of Health, that the first case of COVID in Tanzania was announced
by the Minister of Health on 16th of March. That was last year. And since then, we have only the official data of COVID in Tanzania, 509 cases with 21 deaths. These are the official data given by the Minister of Health or by the government that matter. And I think, remember, as of 15th of May 2020, the government stopped giving the updates on COVID or the data on COVID. And I'm going to discuss this topic based on this paper that has been published by the Tanzanians, the Tanzanian position on the COVID-19 pandemic. So as you can see, the host of this, the authors of this paper, I can see the Professor Abel Makubi, who was by then Chief Medical Officer, who is the current Permanent Secretary of the Ministry of Health. But there's also people like Professor Julie Makani, who's based on Muhimbili Muhimbili University of Health and Health Sciences, which is the premier medical university in the country. But also other Professor Seoki and other colleagues from National Institute of Medical Research. So they try to show the position of Tanzania as far as COVID-19 is concerned. And this paper was published in the Lancet on 14th of April this year. So in February to April 2020, the Tanzania government quickly implemented the various WHO recommended measures to control the COVID-19. And by 27 April, the Ministry of Health issued about 15 initial guidelines of the management of COVID. And we still can remember that the emphasis was put on the recommendations, like hand washing. And I think, for example, our Association, Medical Association of Tanzania, we had the campaign of washing hands, but also with the mask. So I think this also helped us a lot. But we can also remember that the government decided not to implement the lockdown because that would have restricted the public to health services, especially for patients with the chronic conditions, patients like HIV, those with TB, and other non-communicable diseases. So this will have had severe effects on these patients. But again, lockdown might have also prevented citizens from working, affecting household ability to afford food, health care, pushing more people into poverty. So as you can see in this picture, we have Tanzanians who are doing the business, some with masks, so people were allowed to do their business as usual, but by taking precautions. And again, in February this year, you can remember the government reissued the guideline inciting on the WHO recommended measures and build local capacity to produce personal protective equipment. You can remember Muhimbili National Hospital did that. But again, also the medical store department also did that. And again, we can remember that the government has also adopted complementary traditional remedies that are thought to boost immunity, and also the steam therapy that was believed to prevent COVID. So as you can see the picture here, the Minister of Health, the Deputy Minister, and the Director of Traditional Medicine, the Ministry of Health, with as they were demonstrating the local remedies that we have been using, but also another picture showing the person entering to the steam therapy chamber. So the country adopted all those, but despite of all this, but we still see there were no official data update on the COVID-19 as this year, though we had reports from different hospitals and that from homes that there were patients who were there, and some deaths were also reported occurring in the hospital and at home. Though these reports were not given out by the government, instead given the unofficial reports from the hospitals, from healthcare workers who are working on these. And on talking on COVID-19 vaccine, and this is a big topic that is currently going on in the whole world, but also in our social media, in our country, and main media stream, and so it is. People have been talking about the COVID-19 vaccine, and also that there is we have seen the hesitancy on the COVID-19 vaccine. So we can remember that the late President Magufuli urged the ministry to conduct a robust evaluation before accepting the use of vaccine in the country. And you can remember again the government chief spokesperson in his interview with the BBC, Dr. Hassan Abassi, stated that we would like to see the efficacy or accuracy of this vaccine first, and that Tanzania is not in denial of the vaccine. So, but we think that it is not the right time for now. At some point, yes, once the vaccine has been clinically approved. So this showed that the government was showing the the concern with the vaccine, that we should be sure that the vaccines are working and the effects are not much that can affect Tanzanians. So these are like a caution word from our leaders. But you can remember just last week, the president of the Revolutionary Government of Zanzibar, Ali Hassan Mwinyi, issued a statement that the Zanzibar will make arrangement for pilgrims to get vaccine so as to meet the Saudi Arabia's requirement during Hajj. So this is also one of the important statements by the president of Zanzibar that probably open also the door for vaccines in the country. But we cannot talk on the COVID-19 in Tanzania without talking about the special COVID-19 examination committee. So the High Excellency Samia Suluhu Hassan, President of the Republic of Tanzania, announced to the public that on 6th April, her intention to form a COVID examination committee. So the committee worked on 12 terms of references for various areas of disease assessment, as well as COVID-19 control interventions, including vaccine. And in the picture, you can see the Madam President receiving the report from the chairman of the committee, Professor Said Aboud, who is a professor of virology and immunology from Mumbili University of Health and Life Sciences. We also know that Professor Aboud is a lead PI in another trials or vaccine trials on HIV in the country. So the committee has officially submitted its report to the Madam President on 17th May 2021 with 19 recommendations. And one thing to note that the committee revealed that since the outbreak of the COVID-19 in the country in March 2020, Tanzania has been hit by 2 major waves. So this is very important thing to note, that the committee revealed that we have been hit by 2 major waves, though there are no official data on COVID. So by this, we now know that there are 2 major waves. That the first one occurred last year, in February last year, March and April, and again this year from January, February and March. And now, due to the trend of the disease in other countries in the world, there is a threat of a 3rd wave in the country. So that's why we actually requested the presenters who have presented very nicely on this. How can we prevent the country to go into the 3rd wave? So I think we have learned a lot on this. I'd not like to go through the 19 recommendations by the committee, but 2 that I could pick out, that the government should provide information. The second one, the government should provide information on the presence of COVID-19 and take the concrete step to strengthen all interventions at all levels to prevent the 3rd wave of the disease. I think as we heard from the presentations, how we can prevent the 3rd wave and how we can manage COVID at home. So this we have learned a lot, and I think this is a continuous thing, and we should keep learning on this. But again, another recommendation that I can also talk about is that the health professionals must fulfill their professional responsibilities based on the professionalism, norms, and values in educating, preventing, and treating COVID-19 disease in the country. So this is very important. So this is our responsibility as healthcare workers, as association, Medical Association of Tanzania, healthcare professionals in the country, to take our role, to take our responsibility to educate people how we can treat the disease, but also how we can prevent the COVID in the country. So I think I cannot go throughout all 19 recommendations, but they're there. I think we also can remember the number 5, which also encourage on the vaccination. So also committee also recommended the vaccination with they recommend also the different groups that can have the vaccine first. So I think I can end there. I cannot go through all of the recommendation, but I think it is our role as professionals, as healthcare professionals, to make sure that we tell the community whatever we know about COVID, and actually we are not going. We should prevent going again to another wave of COVID, but also to help treat other patients again. So I would like to thank you very much, Mwidimi, and our 2 presenters, and also Dr. Shadrack, our president of the association. So I think I could end there. Maybe we can have questions as we move along. So thank you very much. Mwidimi, are you around? Maybe if there are questions, we can respond, and Professor Trish and Mark can also respond to the questions. I think Mwidimi is muted, so probably.
Someone's put a question in about what do we do if we don't have an oximeter? What criteria do we use? So if you'd like, I can share my screen and show you a score which we're just testing at the moment. Let me see if I can share my screen and show you the recap score here. So this, ideally, without any doubt, the best thing that you should be doing is measuring the oxygen level of the patient using a finger oximeter. But if you don't have that, back in more than a year ago, in March 2020, we didn't have many oximeters in the UK because we didn't manufacture them. They were manufactured in places like China and Taiwan, and we didn't have enough. So we tried to develop a score. Now we're almost ready to publish this, but we haven't published it yet. And we haven't validated this score yet. We've now been doing the validation on about 10,000 patients, but I haven't seen the results yet. So this is a little bit too early, but I just want to tell you the results will be out in the next probably 2 or 3 weeks. And we know that India is waiting for them because they've got a big wave of the pandemic, and hopefully by the time you need them, they'll be ready. So the first thing to say, I think you can see my screen here, there are some obvious red alert criteria. And these are the British ones. You will have your own. But if the patient has signs of shock, peripheral shutdown, if their conscious level is reduced, they've got cold extremities, these kind of things, if you're medically qualified, reduced urine output, that kind of thing. That's the first thing. Secondly, severe breathlessness that has become worse. New breathlessness at rest, newly unable to complete sentences, sudden onset. These are things that you need to send the patient into hospital for. We've called it 999 because that's the telephone number we call to call an ambulance. I'm sure you'll know your own numbers. So those are the red flag signs. Now, putting those aside, we have developed this score, and as I say, we don't know which of these criteria are the most important at the moment. But these are based on the impressions of about 70 clinicians. Almost all of them were doctors, one or two senior nurses. And you can see the criteria we've included are partly based on other scores that we were using in the UK. So anything green is pretty normal. Anything yellow is more serious. The orange is very serious, and the red are those red flag ones that I've already shown you. Now, the heart rate, of course, if the patient's got a very high heart rate or an abnormally and unexplained low heart rate, then there's the degree of breathlessness, or the respiratory rate. We don't know whether the symptom of breathlessness is a better predictor than the respiratory rate, but we will know when we've analyzed our data. The trajectory of breathlessness, how rapidly is it deteriorating? Then we've got a criterion around the oximeter reading. And we know in some parts of London, for example, only 10% of the patients have actually got an oximeter. In other parts of London, 80% have got an oximeter because we gave them one, which was, a donation from Matt and his colleagues. So we will have different cohorts. One thing we think might substitute for the oximeter reading is the symptom of very profound tiredness or fatigue. It may or may not, but that's a hypothesis we're testing. Then there's the height of the fever, or the symptom of feeling feverish with shivers, and particularly uncontrollable shivering. The patients are often quite good at giving you a description which indicates a rigor, and even the layperson can distinguish between a rigor and just feeling hot. So that might be a good one. As Matt said, the timing is pretty key. If today is their first symptom, they are unlikely to need to go to hospital. It's possible, but it's much more likely if it's in week 2 and they're deteriorating rather than getting better. We think muscle aches, in fact, we know that muscle aches predict a more severe illness, but we don't know how much they contribute. Cognitive decline, particularly in the elderly, is a bad sign. And then we've got this criterion, are they on the shielded list? We have a list, or we did have a list in the UK of people with conditions, for example, immunosuppression, if they're taking steroids, diabetes, all sorts of things on the shielded list. And then other risk factors for poor outcome, particularly age. Age is the biggest predictor of poor outcome. If you're young, even if you've got some of these other risk factors, you're probably going to do better than someone who's 90 who doesn't have any specific risk factors. So what we're doing now is we're following up, we're measuring all these things in a very large cohort of patients, and then we're following them up to see if they die, frankly, and also whether they're admitted to hospital, whether they're admitted to intensive care. And we've been doing that for a few months. And as I say, we are now at the stage where very soon we'll be able to report to you which of these criteria are the most important. But we already know that the most important is the oximeter reading. So if your patients can get hold of an oximeter, if you can buy them one or lend them one, that would be ideal. Is that all right, Matt? Do you want to add anything to that?
That's a wonderful summary, Trish, and certainly our future direction of travel. We're waiting very intently to see what RECAP comes up with. From a pragmatic perspective, pending RECAP, and I don't know if this is useful, we produce this that you're very welcome to borrow, translate, do what you like with, essentially, to bucket patients up into 3 main areas: who's mild, who needs to contact someone in healthcare for a...
Matt, can you share your screen properly? Because we can't see it. Can you blow it up?
Is that, oh dear, gone too far. Is that
bigger? Yeah, that's better.
Yeah,
yeah, that's perfect.
This
well done.
No problem. So this was all about who's mild and ensuring that people were aware of what was normal, what the kind of in-between group was from a symptom perspective. And as Tricia mentioned, if you're lucky enough to have an oxygen saturation meter and what that means, and then the red, more severe group of who needs to seek help immediately. And I think that sort of public information, as simple as possible and as colourful as possible, would be potentially a strategy that could be used.
Yes, thank you very much. It's fantastic. Is there any question? If you type your question down here, we'll allow a few more questions before moving to Twitter.
Sorry, Mudim, if I can ask maybe experience from our colleagues. So here in Tanzania, you know, as I say,
I don't think you can hear you. I don't think you can hear you, Alicia.
Yes, I was asking that in one of my slides, that in our country we have been using and also we've been using the steam therapy at home, mostly at home. So from our colleagues, is there evidence on this, probably on your experience on that, of using the steam therapy, for example, in diseases like COVID?
Okay, I heard about this the first time today, that it's very popular in India, apparently, steam therapy. I do not know any evidence that steam therapy is beneficial. I can think of reasons why it wouldn't be. On the other hand, I spent some time in Finland and they use a sauna for a lot of respiratory diseases. Matt, do you know any better than me?
No, I'm intrigued actually to see if we've got any evidence to back it up. I think the thing we've been recommending, certainly from a pragmatic perspective, and again, light on evidence, is teaching patients how to prone themselves at home, you know, and do breathing exercises to maintain respiratory function. But again, light on evidence in terms of demonstration, although it is something we are teaching patients to do in hospital beds who haven't required or who have not quite got to the point of requiring ventilators. So this idea of moving around, lying on your front to increase your respiratory reserve and your alveolar usage is a common sense kind of intervention. But again, we need to prove it.
Can I just say, I've just done a quick Google search. So there's two things that about steam therapy. One is using it to treat COVID, and the other is using it to prevent COVID. It looks like there's no evidence for either of those. It also looks like there is now a randomized controlled trial of steam therapy for the treatment of COVID, which is currently recruiting in America. But the advice is do not use steam therapy until the results of that study are out. And in relation to prevention, there is no evidence whatsoever that it is beneficial, but there's also no evidence that it does harm. So you know, it's like a lot of things in this pandemic. I think you've got to keep looking for the results of research and then make your own judgment. But I know how easy it is to panic when there's a wave of COVID about. And then whatever anyone else is doing. Remember hydroxychloroquine? Remember all those funny things we were doing a year ago? They were actually harmful. They did kill people. So be careful.
Yeah, one more question before we go to Twitter. Right, okay. So, yeah, I'll just welcome back Shadrach to come and thank everybody and close the meeting before we move to Twitter. But really thank you very much, Trish and Matt and Alicia and Shadrach, and for putting this whole thing together. And I'm really pleased to be able to help in a little way. So,
Mudimi, sorry, before we close, before Shadrach, maybe I'll have a request.
Yes.
I think we really need to have the series of these presentations so that we can learn. We can have discussion and share the experience from different part of the world concerning COVID. So if it is possible, maybe we can have the series of these presentations. That is my request.
Joe's hand is up. Have you got Joe?
Yes, I don't know whether you can hear me.
Yes, we can. Yes,
yeah, sorry, I put it on chat, but obviously maybe you didn't access that. This question is really directed to Dr. Osati. I don't know whether he can hear me. It's really to do with the situation in Tanzania. I just wondered, because for those of us who are interested in what's going on in Tanzania, our main concern is that if vaccination is going to be implemented, the exercise is obviously going to be very complex and difficult. Now, but also probably even more challenging is the prevailing environment in the country, because anti-vaxxers have had a field day. That's the reality of the situation. The population is very skeptical or ambivalent at best about the vaccination, because there has only been one narrative up until now, and that is vaccination is bad. So does the profession have any strategy on how they are going to help the authorities to maybe start turning this around? Do they have a platform, a strategy, first of all, and secondly, a platform? I mean, you can talk in webinars like this, but this is navel gazing. It's among professionals. We don't need to be converted. It is the people who will need to have their mind converted. Is there any strategy to achieve that? Thank you.
Dr. Osati.
Thank you, Joe. Thank you, Joe. I think that is a very valid question, and it's very challenging, as I said. And as you know, the anti-vaccine, the hesitancy is very big, in our country. But again, we can see this in social media, and we can see the reaction. So I've been doing some.
Can I say something here?
Yes. Well,
is that all right?
Can I,
sorry.
Yeah.
Yes, when you finished, Elisha.
All right. So I think Dr. Buguzi is here, and Dr. Shadrach is here, and everybody else from our part of the country. I think we have a big job to do on this, and the first thing is government be on top of everything. So the first thing that we insisted that the president to form the committee, something which he did, and then the committee come with the recommendations. So one of the number 5, which is that we should go with the vaccine, and the committee actually revealed that the vaccines are safe and effective to be used. So the big thing that we need to do is now the public campaign, and to try to convince the campaign. But I think the government has to come in also, and the strategies probably as association, as the professionals, is not yet on, but I think we now need to reorganize ourselves as professionals, and to see and actually advise the government again, and actually we'll be needing a lot of talks on the hesitancy of the vaccine elsewhere, so that we use that as an experience to support the vaccines in our country. So the challenge is big, as you say. Matt, maybe you can continue, Trish.
Yeah, I fully agree with everything you said. I just wanted to also say that we need to distinguish between anti-vax views and vaccine hesitancy. And there's a lot of vaccine hesitancy around, especially in a country that, with respect, has had a lot of misinformation circulating, and also senior leaders a few months ago were giving out a very confusing message. Now you've got, I think, a more consistent message coming from your leaders, and it's a more kind of scientifically based message. Of course, you have a small proportion of anti-vaxxers. We have them in the UK, but the majority of people who are reluctant to get vaccinated are, I would say, vaccine hesitant, not anti-vax. And one of the things that they need is somebody who can answer their questions, because I think they will learn and they will come round. Most people are not stupid, you know what I mean? They've just been given the wrong messages. So I think I would have confidence in the people of Tanzania and make information available. And I think, you know, half of them are going to be okay with vaccination straight away. And then slowly, people will come round. This is what happened in America. And they're gradually vaccinating everyone. That's what I think. I hope I'm right.
Yes, I agree with you, Trish.
Thank you so much. May I contribute a bit? I think the question of skepticism about the vaccine is very sensitive something very sensitive. And so far, you can't blame people for being skeptic. It's our role, knowledgeable people, health professionals, to educate them once the moment comes. For the time being, the task force report has been submitted to the president. So far, what we are waiting now is for the government to respond. Once the government is going to have a positive response towards implementation of of vaccination in the country, is when other groups are going to chip in, including these health professionals. For the time being, it's so difficult to put clear strategies as if we are going ahead of the government. So let's pay respect for some time now, waiting for the government response. And then after, as my colleague have asked, I think we wish to have a series of education. We wish from Professor Trish, from Matt, to have a series of education. Is going to be very helpful to us. Although today the participant is about 50, is about 17 in Zoom and about 18 in YouTube. But I think those people who have already attended the meeting, we are going to be very good ambassador. Once it comes to the outbreak, we're going to be very good ambassador. So what you did today, your talk is very fruitful. Personally, I learned a lot of things from Trish and from Matt. So thank you so much for this.
Maybe if I can add something that on top of what Dr. Shadrack has said, you know, in our country, we are not blaming anybody on whatever the approach had been taken, because we know in the world we had two approaches that were competing. We had the lockdown approach, but we have those countries who believe on herd immunity, like in Tanzania, for example. But now we have that approach, which is a vaccine. And Professor Trish, as you said it, so there is hesitancy, and actually people just need education. And Dr. Shadrack, you said it very well, that the committee has come with the recommendations. Now we're waiting for government, for Madam President and her government to, if she will accept the recommendations, and then we have a move together. And I think this move should start from the professionals, and I think this forum can be a very good start point. And as if we all agree and have those serial presentation, and probably the next topic could have been the COVID vaccine. Very much again.
Donatus, Dr. Mutasingwa, you just want.
Yeah, thank you so much. Thank you for the speakers, Trish and Matt, for the excellent presentations. I have a question and a comment. I live in Canada, but I'm originally from Tanzania. But the comment is my observation about any public health interventions in any country, including Canada, is it works very well once you have the consistent messages from the leadership. So I think
from what I'm seeing so far, with the release of the COVID task force in Tanzania, they report the recommendations. I am seeing a message that's positive. So I think once the government decide to go ahead, I'm not worried about the implementation, because although they're a little bit behind, but I'm sure that they will hurry up and come up with a strategy. But maybe what the association of professions can do right now is to organize this kind of series, education, learning from other countries. There's no need to reinvent the wheel, because people have gone through this. They've had some setbacks. They know the mistakes that they've done. They could share the lessons that they saw. So this is probably what the MAT can do now, to organize, learn from others, different countries, African countries, everywhere. There's no need to restrict knowledge acquisition. I think that could be one of my advice to the association. And if you stick with the professional, I think you should be fine. Now, the question that I had for the speakers is, I know UK went through different waves. Even Canada, we are now in the third wave. Can you share what are the lessons that maybe the mistakes that the government or the country made when things were going well? If you could share that, and I think that would be helpful as well.
How long have you got? My own view is that politicians do not understand exponential growth. And so, sure, we had a very bad first wave in the UK, and then things got much, much better last summer, and it looked like COVID had gone away, but the virus had not gone away, and it was still spreading exponentially. But because the absolute numbers were low, the government decided that they would ease lockdown and basically let people go back to normal. There was a lot of pressure to get people back to work. The economy was suffering, all that kind of thing. We should have locked down again in September when cases were rising, but still the number of cases was relatively low, because if we had locked down, I think we would have reduced the height of the second wave. I think another mistake we made was we did not introduce masking early enough, and we didn't enforce it strictly enough. And the third thing, I think, and this is a mistake I think our government is to some extent still making, is there is an overemphasis on droplet precautions compared to airborne precautions. So I had a message from someone, a colleague of mine, who went for vaccination today, and she said they were scrubbing down all the seats that people were sitting on, but the windows were closed. Well, nobody's ever caught COVID from sitting on a seat, to my knowledge, but they've certainly caught it from shared air. So those are the mistakes. I mean, there's probably many other mistakes. What do you think, Matt? What other mistakes did we make?
Fantastic summary. I agree with all those points. And to add, I think we over-focused on hospitals and intensive care units in England, with not enough on the community, people at home. And I urge you, with the time you've got now, to think about how to build those regional networks up, so that if and when third peak happens and fourth peak after that, you've got your communication channels, you've got your quality improvement networks in place to move rapidly, and embed some of the principles from around the world in terms of how you monitor and keep people out. And like Trish was saying, it was a difficult thing to prove and demonstrate that this was the right way forward. But, you know, we know that population health management is the most important element here. It's not about 1% of the population. It's about the welfare of the entire country. And that is achieved through good community care. And I say this as a hospital specialist. And, you know, we need to turn the tap off and ensure you have an educated public that adheres to all the elements of preventative care that Trish says. And the sharing from around the world is an offer on the table that is unconditional. You know, everywhere has learned from everywhere else throughout the pandemic. You only have to ask, and you'll be inundated with people wanting to help you going forward. So please don't feel scared to ask, and that's what we're here for.
Fantastic. Thank you so much, Matt. And I hope you've learned something new here today, and certainly I have. And I'm sorry that my camera is not agreeing to go on. So what I will do, I will pass it to just to Elisha or Shadrach to close, and then I will we shall move to Twitter. Okay.
Thank you so much. Thank you so much, Dr. Ndosi. Thank you for all. Thank you all speakers, Professor Trish, Dr. Matt, and Dr. Elisha. Thank you all participants, and I'd like to thank you all the organizing committee. I think this talk has been so fantastic. This is the first time, so I believe in the second talk, once we are going to organize again, it's going to be very good, and the information we are going to disseminate very early, so that the number of participants is going to increase. Today we expected to have about 300 participants, but unfortunately we have about I think 60. The main problem in our country, we had a big match. One of our club was playing today, so most of the people almost it was on the same time, so our talk was being affected by that. So I think next time, once we organize, we're going to have a very good number of participants. The legacy you have put in our professional, in Tanzania health professional, Professor Trish and Dr. Matt, is very big. Take it from me, it's very big. And those who have participated today, we're going to be a good ambassador to disseminate this information. I think I'm going to be working closely with Dr. Ndosi so that we can communicate closely and have some slides and to share some knowledge and some experience as we have shared from different countries. Thank you so much once again. Thank you, the organizing committee. Hope to see you next time. All the best.
Thank you. And I think, Dr. Ndosi, you are going to share the recordings of this program.
Yes,
yes. In the
YouTube. Yes. Right. Yeah. So we'll get the recording together, and then we'll share it, and it will be on with Matt as soon as possible. Once you quickly see the files and how they come up, and then we'll share them.
All right. Thank you so much. Thank you.
So if people can move to Twitter, this hashtag is, I hope I can still tag, yes, keep COVID away. And if you've got any more questions, we'll answer them there, and all speakers will answer the questions there. But thank you very much, everyone. And we're going to close now.
Thank you.
Bye. Hello.
Yes.
Hello. See, my camera is off. I can't. I really just can't. I don't know what happened. Somebody must have taken me off, I'm sure.
That's too bad. I don't know what happened.
Let me have a look. Let me see if anything. I think everything is intact. It's just I think it's just to do with perhaps to do with the camera. Let's have a look. Okay, Syriacus, usiondoke Syriacus.
Yes, and I'm still around.
All the controls have gone. So what I'm going to do, I'm going to try to close and then I'll come back. We'll stay online.
All right.
I hope you can see all the chats if there's any question that needs to be taken through.
Let me see if there are questions on the chat here.